So there is a whole section at the end of the EMS manual that outlines the quality management program, and I'll be referencing that throughout. But the fact of the matter is, though the County of Fairfax has paid me to be the quality manager for 23 years now, the fact of the matter is that each one of you is a quality manager. I get paid, I get the title and the headaches, but even the recruits that graduated on Friday from the 165th Recruit School are more of a quality manager than I am. Because each and every day that you are on the street providing care, you're managing quality either by what you encourage to happen or what you ignore it is happening. From a global perspective, the quality management program is intended to meet this purpose: to evaluate service delivery and appropriateness of care, assess patient care quality and processes, and identify opportunities for individual process or system improvement. The fact remains that every time you look the other way when Todd's being Todd on a scene, if it's not enhancing the experience for all involved, you're managing quality. So we need to, if we keep talking about changing the culture in this organization where EMS is as cool as being on the USAR team or in the evolving special operations world, in any case, we can change the culture by changing our expectations, by helping coming to a consensus about what it is we are trying to provide. So in 2003, the Commonwealth of Virginia saw fit to make quality management programs a requirement for every licensed agency, every licensed EMS agency in the Commonwealth. Says we have to have a quality management program. Doesn't say you have to have a quality manager, you just have to have a program. And that it looks at all aspects of care, from call intake to exit. We predated this program by a year, and I've been party to helping support quality management program establishment both here in Virginia and somewhat across America. So what is quality care? How do we know? What is it? Shout it out.
Meeting the expectations of part of it is of our protocols when you're running a call.
Okay, so meeting expectations through compliance with protocol.
Treating people how you want to be treated.
Treating people how you want to be treated, that's a noble one.
Quality care doesn't discriminate. It doesn't discriminate if somebody is drunk that you're running. It doesn't matter if there's somebody that is, 40 years old, 50 years old, whatever you might have a bias to. You don't take that.
Okay, so it's non-discriminatory, and can I extrapolate and say non-judgmental, that I may be drunk and stupid, but I still am eligible, should receive care? Okay, what else?
It defines performance metrics that you look at on every call.
Okay, who sets those rules? Who defines the metrics?
OMDs.
OMDs. Who else?
As I mentioned, the quality program manager.
On my dreamiest days, yes, perhaps I do. So OMD, who else sets the standards? So, National standards, National Registry. Registry sets the standards for educational programs and what it takes to get the card, but they really don't establish standards for care.
Yeah, so that would be
There's the national.
There's some state level or that has
EMS. National care standards.
There are some national care standards, yeah, that's true. There's the international standards with regard to resuscitation from ILCOR, the International Center, I forget what all those letters stand for, but yeah, there are some national standards in terms of prevailing perspectives on ACLS and trauma care from the American College of Surgeons. The National Association of EMS Physicians has written a number of position papers with regard to best practices, but the standards do vary from agency to agency and community to community and state to state. Just like like any agency, the EMS system you get is the one that you designed, and the standards that you set and the expectations that are shared define what that system's going to look like. So how else do we know what quality care is?
Outcomes.
Outcomes, sure. And is that based on patient lived or died? Is that based on?
Yeah, it depends. It could be patient lives or died, or patient, did they return to what would be a life that doesn't require a lot of assistance? Do they return back to a normal?
Okay, so survival to baseline, return to baseline, whatever that was, if that was that. They lived to get to the hospital. They lived survival in and of itself. How important is our clinical impression matching the hospital's clinical impression in terms of determining quality?
I think it has some form. It's some connection, not necessarily always, but if we're treating the wrong thing in the field, right, that's not quality, right?
Right.
You thought you were treating an MI and you were actually treating asthma, and it was actually asthma, right? Now they're not getting asthma care.
Right.
So that there is some correlation.
Yeah, it's always nice when our primary impression is validated by their primary impression and their discharge diagnosis. Makes us feel like we've done all the right things. How else? How else do we know we provide quality?
Patient feedback.
Okay, patient feedback. How much patient feedback do we get?
Usually get the negatives, I would think.
In my personal experience, I have had more negative reports than I've had positive ones. That's true.
But also when you talk to patients, like, hey, thank you so much.
Mm-hmm.
You get that immediately.
Yeah, and there's the family that comes by the station and brings cookies or pies or ice cream, or brings the baby back to see the firefighters that birthed her in the front seat of grandma's old Ford sedan. How else? Do we need to join hands and try to contact the living? I feel like I'm talking to a bunch of zombies this morning.
Follow up with you, so we send an email, we get the patient follow-up, which is a great report that comes from your office. And we provide that so we can follow up, like, what happened to the patient.
Right.
And go over it with your crews to continue that system of quality.
Right, and we do have actually two ways that we get outcomes. If they've been to the ANOVA system, you get the one-liner that says this is what the diagnosis was, and there are some people who wait for that, and if it still makes them go, then they request it. I got several of those the other day that were dating back to April, and I was like, seriously? Now you want to know? But they ended up being really interesting cases. Dr. Weir.
Can I share some thoughts? Because this weekend it was really kind of interesting. Two things. My middle daughter is an art student. Yes, I'm still working for that. And my youngest daughter, they're back and they're talking about it, some kind of social thing. And they're like, is satire still satire if no one gets it? And that was a philosophical question, right? Is comedy still comedy if no one laughs at my joke? I treat myself, I still laugh. So that's a little bit like quality. What defines art? What defines satire or comedy? What defines quality? It can be a really difficult kind of esoteric term
Yep.
to define, but things that are interesting as well, like if I wear a tuxedo to a Metallica concert, I'm out of place. That's a little odd. There is an element that your local community defines what quality is.
Right.
A system, meaning the patients, the downstream providers, the providers themselves, you help determine what is quality. Just like the Metallica brothers determined, damn man, a tuxedo doesn't belong here. I get sideways glances. And then I'm a simple man, right? So I can't remember things. Corey Slovis loved them, between the 3 and 5 ways of remembering things. So I remember the 5 Ds, because we all want to make a difference. Everybody, at the end of the day, everybody just wants to make a difference, have an impact. We want to lead an impactful life. So among the ways that we can think about quality, or maybe like, hey, what have I really done today? At the end of the day, I ask myself. So there's the 5 Ds in EMS that can help us measure our impact. Did we make it better? Death, disability, disease progression, discomfort, and destitution. So death, that's mortality. The patient lived or died. Disability, are they left with a GCS, or not GCS, I can't remember the term for the cardiac arrest outcome, but whatever. They can't dress themselves anymore. They can't feed themselves. They need
CPC.
Thank you. Disease progression. Well, that would be an element where I didn't identify the right diagnosis and it kind of progressed, whereas I could have maybe lessened the progression of the disease. Like say sepsis, by early identification and intervention. Discomfort, symptomatic scores. There's like the dyspnea score is a measure of how short a breath a patient is. Pain scales is a way that we can look at, did we bring light on this call? Destitution, because yeah, we can live on real valuable contributions, but if we can't sustain it, afford it, or we leave the patient destitute because we bankrupt them with our healthcare system, and we haven't really done them a solid. So those are some 5 ways that can help me reframe when I struggle and I'm sitting saying, look, how do I define that difficult term? Thank you for the opportunity to share.
Thank you for sharing. So we get feedback from the hospitals. We get it sometimes in the form of complaints, and we based on an individual interaction. I was on a tear when I got there, and I took it out on the nursing staff. Those usually come back to me fairly quickly. We also get feedback in clumps. We get what has been monthly reports but is now going to quarterly reports that we get back from Ruston Hospital Center Trauma Services that says, here is every trauma patient you brought us, and here's how things went. And oh, by the way, among this group of patients, we have some concerns about. Why were they so long on the scene? Why did X, Y, or Z happen? We get those from Ruston. We get monthly STEMI outcomes in bulk from Ruston. We get intermittent case feedback from the ANOVA facilities, kind of based on volume and competing priorities. But so we get feedback in a variety of ways. And the next question is, what do we do with it? We also get feedback from you and your colleagues in the form of sometimes people make a formal complaint about how care is going. Sometimes you solicit a call from a citizen or a complaint that arrives through a variety of sources. In my time in this position, I have received notice of concerns that came through the fire chief's office, that came through the members of the Board of Supervisors, and on one occasion from a member of Congress, because that's who the person chose to notify that they were not happy with the care provided to them by Fairfax County Fire and Rescue when they called 911 for a medical issue. And then there's people just call. They call the fire department number and often get routed to me. So what do we do with all that information? Sometimes I feel like I'm a colander, that I'm just sifting, or a sieve, that I'm just sifting things back and forth to figure out what really is an issue and what really is not. I'm not denying, and if you've seen any of my correspondence to citizens, you'll find that I have kind of a throwdown phrase that I use when I've been on the phone for minutes or longer with a citizen not happy about their encounter with your brethren providing care. The situation as you described is not consistent with our expectations. Doesn't say they're right. So anybody that says, oh yeah, she always takes the citizen side, not so. I'm just saying, yeah, the way you're telling this story, that would really suck. Not saying that's how it happened, And everybody's got their own view of it, so we're never going to get the, until such time as everybody's wearing body cams, all places, everywhere, all the time, we're never going to know what really happened. And even with body cams, you've got 5 people with body cams, and the patient's got a body cam, we're still going to have 6 different views of what went down.
So I got
Yeah.
a quick question, right? I can imagine, like, most of the time, people call it just for, like, because the patients don't know the protocols. It's probably somebody-
Well, some of them do, because they've been treated by the same ones so many times.
That's true. You're right about that. We got our freaking fly. But I bet a majority of that is just people just being rude, right? Just not treating people
Yep.
with respect.
Yeah, because when I get complaints or when I get calls about how happy people were with their care, it's not, boy, Adam read an EKG like a frickin' rock star. He recognized that abnormal rhythm in under 60 seconds and gave me and did XYZ for it. No, you're exactly right. They talk about how kind you were, how thoughtful you were to include the spouse in your discussions about plans of care, the fact that your colleagues picked up all the crap that we threw around the living room while we were trying to provide said care, the fact that we didn't kick the dog on our way out the door. All of those things, it's how you made them feel that sticks with them. And if I were going to write a motto, it would be that people feel not only taken care of, but feel cared for. Because even when things go badly, I mean, there have been countless studies that looked at people who sue for medical care issues. If people felt like they were taken care of, that the person providing the care was doing their best, they aren't going to sue. They might not be happy they took the wrong leg, but they aren't going to sue because it was an accident. But if they think you were demonstrating maximum assholery throughout the course of their time with you on scene, they are going to find fault, even if you did everything by the numbers. So we need to work on our soft skills as much as we need to work on our IV prowess and our accuracy of EKG interpretation. Anything else? How else we would know?
Relationships with the ER doc and the nurses.
Okay.
If you have a good relationship, you can, hey, that was a challenging call. Is there anything I missed? Is there anything you would have done differently? So that would sharpen your skills when you get back out in the field.
Yep. Anything else? Okay. So these are the aspects involved in quality management. All right, things are falling apart.
I'll fill in on that. Some of the ways that we know, like, get insight into quality a little bit, like the quality of your experience is, like morning rounds. We start morning rounds by asking, what are the biggest challenges that chafe your ass when you're out trying to deliver care? What are barriers that we can remove? What are things that we can make better tomorrow than yesterday? And we ask the people who are delivering the care what kind of challenges and difficulties they're encountering. Sometimes we get them, sometimes we don't, but we always leave the door open and solicit it every time. When you're out there sweating and bleeding with your brothers and sisters, you let us know, hey man, I'm having difficulty with this widget. I'm trying to accomplish this clinical skill, and the light's just not bright enough. I don't know whether it's my eyes or the light, but it fogs up and it sucks. Is there a better widget out there? That's a great question. Sometimes it's the stuff we use to deliver care. Sometimes it's the place we deliver care. We'll get into a little bit more about that. The other place that we see it too is, well, in the few window hours that Dan and I get to be out there, we see it. But we also see it in a simulated environment wherein we bring providers up to run clinical-based simulations, and we can understand and get insight into some of the challenges. I'll tell you, that's where we simplified things like the dose of midazolam. Why the frick was I making you do 0.15 times the kilograms? That's hard math. We went to the P's and we're like, dude, can we just make it 0.2 or 0.1? Because that 5 at the end just makes it so much harder than it needs to be. They're like, yeah, why are you thinking so? So when we see that we're trying to draw up Solu-Medrol out of the little hard-ass plastic cap with the ball that you gotta drive down to get the syringe in, and we're seeing the poor shaking hand intern stab himself in the thumb. We're like, why don't we just use dexamethasone? That doesn't come in a bottle like that. It's so much easier. So those are just some of the ways that we try to get a bearing. Like, where are we going? What is are we off the trail? Are we like, do we need to double back? Where are we? So we're grateful that the organization gives us those touches, those opportunities, those insights. And only if a provider, only if one feels safe enough to share that stuff. I want to tell the medical director I'm having trouble intubating with this crap-ass laryngoscope that you gave me, because then he's going to think I stuck an intubate. Okay, or maybe I think that I gave you a lousy hammer that falls apart in your hand when you're trying to drive a nail. So, it's cool that this organization gives us those opportunities. And it is awesome, I'll say, now that we are, or when we get, to a place that we can be as transparent and vulnerable with each other to share that kind of stuff. So I'm grateful for that, and hopeful that it continues and evolves even further.
Yep. So, part and parcel, it all starts at the beginning here with quality planning. When we are in a dynamic phase with EMS manuals where we change things as they need to be changed. But even when we're starting new programs or processes, it all begins with quality planning. EMS leadership, whoever's carrying the flag for a particular item, for instance, Bailey and blood, we sit down and we figure out, okay, what are the pre-implementation things we need to do to set us up to be successful, to do the right thing. The next piece is the quality assurance piece, which says, as we are implementing it, what are we doing to ensure that we are doing things right? And then the quality control piece is kind of reinforces that. It's post-implementation, and then it's, are we doing the right thing right? And lastly, the quality improvement piece. And that's where, for instance, we found that people were not using pelvic binders when patients clearly had the potential for significant pelvic injury. Well, part of it was because they weren't co-located with any of the stuff you needed when you were taking care of a trauma patient. So it was an out of sight, out of mind kind of thing. And once we start putting pelvic binders closer to backboards, because you often need spatulas when you're moving trauma patients, the use of pelvic binders went up. We found that based on feedback from you and your brothers and sisters in the field that X, Y, or Z isn't working very well. Okay, we've got an equipment committee that will take a look at things you want to consider. We have a variety of ways to provide that input, and then we determine what we're going to do. Among the ways that we keep this whole party rolling is through this listing. It starts with peer review, and I know it's not the peer review that some agencies do where every report is read by a counterpart. We have discussed down the road that as the EMS lieutenants in the chase vehicles, EMS specialists, whatever the name du jour is, once you get your feet under you and you get to feel solid and comfortable and nailing it with all of the skills and capabilities ascribed, anticipated for that role, peer review, reading each other's charts may be the way that your role in CQI is going to start. Because you're not the bosses of other people, so it doesn't make sense to put you in a supervisory role, but certainly peers reviewing peers is a reasonable beginning. And that's not to say that somebody can't say, hey Adam, can you take a look at my PCR? You were on this call with me, does it make sense? You should read every narrative for the PCRs that you are co-signing. Or if you're the author, you should have Schmedlap, who was your driver, who was also on the call, read that narrative and ask if it's telling the same story. Because some of the silly things that make their way to EPCR narratives would probably be caught if somebody else other than the author read them. It's part of the reason we turned off the dictation capability, because of the curious things that were showing up in narratives. You were telling a lovely story about your patient, but Todd came in and said, hey, did you see the new nurse? Holy sh-. That made it into the narrative. It wasn't caught by the author of said narrative. So that's why we don't use that. The ambient noise pickup may be revealing in countless ways. John?
I think of peer review also as like just kind of hot washing, like talking about, I mean, I just ran this weird call or this interesting call.
Yep.
What, like, this is what I did, what are your thoughts? Like, you do it all the time in the firehouse or, you know, hopefully HIPAA compliant, but it kind of helps us kind of walk through, okay, I would have done that a little differently, or yeah, that makes sense, I could have found myself in that same spot.
Yeah.
Falls under training quality. It's exactly. That's for sure.
And it is good to have those conversations. You just need to be mindful when you're having those peer review kinds of conversations that you do it in a way that is mindful of your surroundings and who may hear them. Here in Northern Virginia, EMS rooms and accesses are a bit different than they were what I was accustomed to in Minnesota. But I can tell you that on more than one occasion, medics in an elevator or at the coffee